Hi, and welcome to today's live Dermcast event entitled The Skin May Just Be the Beginning, Pre-Psoriatic Arthritis and Clinical Clues of Psoriatic Arthritis in Patients with Psoriasis. Thanks so much for taking the time to be here. I'm excited to dive in with my colleague Alexis Neal. My name is Jane Mast, and I represent Novartis as a Regional Medical Director. Today, I have the opportunity to be your facilitator for this program, along with my colleague, Alexis Neal, who is also a Regional Medical Director at Novartis.
Hi, this is Alexis. We're both very excited for today's live Dermcast.
We will begin today's program by hearing from John, a patient with psoriasis and psoriatic arthritis. John will walk us through his story to diagnosis of psoriatic arthritis, or PsA, and the impact it has had on his life. We will then discuss the epidemiology, clinical presentation, and diagnosis and screening of psoriatic arthritis with an emphasis on the early signs and symptoms that can help you identify patients at risk for developing PsA in your own practice. As we will hear from John, it is critical for us in dermatology to intervene early and effectively in these patients at risk for psoriatic arthritis. Let's listen as John describes his experience with psoriatic arthritis in his own words.
Approximately 40 years ago, I was diagnosed with psoriasis, and recently I was diagnosed with psoriatic arthritis, which I believe that I've had for a considerable period before then. It's been a long journey since the diagnosis. My name is John. I'm a 65-year-old father. I'm married 28 years. I used to be a big walker and hiker. Essentially, the psoriasis was manageable, but I was having a lot of pain in my feet. I had problems with my nails and my toes specifically. Walking was very, very painful. Every step I took, it hurt. My father died in 1989, and he had a lot of the symptoms now that I have. He had them earlier. My feet claw. My father's legs went like this. My feet do that. So that's the damage. I was in pain. Think about it, 24 hours a day. You can't hide that or diminish the fact that when you're in pain, you're a different person. You know, I was not kind and gentle in those days. I knew at that time I had to do something and do something fast. In talking to my rheumatologist who diagnosed my condition of psoriatic arthritic condition, I see him almost as a hero. I'm not the kind of person to use that term, but in a way it's true because that diagnosis changed somebody's life, mine. And, you know, I keep on saying that, but I mean it. I can't imagine what life would have been if this continued. Getting the diagnosis really opened my eyes. I was able to have an answer. Looking at these questions that could have been asked about this disease, it falls into two categories. Questions I didn't ask and questions that the doctors didn't ask. And I can specifically go back to a dermatologist on that. What's your family history in regard to arthritis? Or maybe you should watch out for this later on. It didn't happen. It never occurred to me that it would be connected to the arthritic condition. Never occurred to me. And at that point, when it became a problem, a lot of damage that I experience now was done. People with this disease should know that it is really something that affects your lifestyle as well as your life. It's up to you to ask the right questions to your patient to determine whether or not the psoriasis is going to lead into psoriatic arthritis or not.
Now we'll speak briefly about the epidemiology of PsA, as well as some barriers to diagnosis.
Approximately 40 years ago, I was diagnosed with psoriasis, and recently I was diagnosed with psoriatic arthritis, which I believe that I've had for a considerable period before then.
A recent analysis based on data from the National Health and Nutrition Examination Survey collected from 2011 to 2014 estimated the prevalence of psoriasis in the United States to be approximately 8 million American adults. Analysis of electronic medical records in the United States placed the annual incidence of psoriatic arthritis at 2.9 events per 100 psoriasis patient years. Overall, it is estimated that up to 41% of patients with psoriasis may also have PsA. The Corona Registry, a large observational database of Americans with psoriasis who are receiving systemic treatments, was launched in 2015 in collaboration with the National Psoriasis Foundation and has enabled comprehensive study of clinical assessments and patient-reported outcomes in this patient population. Importantly, analysis of these data has demonstrated that the presence of clinical signs and symptoms of PsA were not associated with psoriasis severity. This aligns with previous findings in the literature, where it has been estimated that up to 15% of patients with psoriatic arthritis developed arthritis symptoms prior to or simultaneously with skin disease. Because patients can develop PsA independent of psoriasis severity, it is important that we as clinicians remain vigilant for the warning signs of PsA in all of our patients with psoriasis, not just those with more severe disease. Jane, what do we know about the potential impact on patient outcomes when these warning signs are missed?
Well, as we heard from John, the patient journey to diagnosis of PsA can be long, and delays can lead to significantly worse long-term outcomes. Missing or delaying a diagnosis can be profoundly impactful for the patient, and research has found that delays in identifying and treating PsA as short as 6 months can result in debilitating long-term damage that severely limits physical mobility as patients' joints erode and deform. We know from observational studies that early intervention has been shown to mitigate these effects and improve patient outcomes. So why are these diagnoses being delayed or missed? Well, for one, psoriatic arthritis can be challenging to diagnose, especially for non-specialists or non-rheumatologists. A web-based survey of more than 200 American adults with psoriatic arthritis found that the most common misdiagnosis for PsA were obviously other forms of arthritis, right, including rheumatoid arthritis and osteoarthritis. But other common misdiagnoses of psoriatic arthritis include bursitis, fibromyalgia, back problems, and sciatica. Also, these patients are often misdiagnosed with anxiety and depression, highlighting the significant impact this condition has on the psychological quality of life for these patients. And respondents also indicated that their symptoms were often not taken seriously or assumed to be psychological in nature. Responses from the same study indicated that patients generally saw a variety of healthcare professionals on their journey to a diagnosis of PsA. These healthcare professionals included primary care physicians, general practitioners, sports medicine specialists, chiropractors, and dermatologists. While rheumatologists are often well equipped to diagnose PsA, there is a recognized lack of awareness regarding the early warning signs of PsA among other disciplines that contribute to delays in diagnosis as patients navigate the healthcare system. Psoriatic arthritis can be especially difficult to diagnose in the absence of skin disease. While certain forms of psoriasis are linked with increased risk for psoriatic arthritis, the development of psoriatic arthritis can occur independently of skin symptoms. So the diagnosis of PsA in a patient with severe skin disease may be easy to make, but diagnosing the same patient with PsA that has very little skin disease can be more difficult.
The psoriasis was manageable, but I was having a lot of pain in my feet. I had problems with my nails and my toes specifically. Walking was very, very painful. Every step I took, it hurt.
Psoriatic arthritis can manifest in many different ways across the body. As we know, skin disease is strongly associated with PsA, particularly scalp, nail, and inverse psoriasis, as we'll discuss later. Beyond the skin, patients with PsA can experience peripheral arthritis, dactylitis, enthesitis, nail dystrophy, and axial disease. Many of the most noticeable manifestations predictably involve the joints, such as stiffness or pain while at rest, warm, swollen, or tender joints, and reduced range of motion, which are all common first symptoms that can prompt patients to seek care. These are the types of clues that are more obviously signs of psoriatic arthritis, and asking targeted questions about musculoskeletal inflammation should be a key strategic tool for you as you try to identify your patients at risk of PsA. Outside of the joints, other common initial symptoms of PsA that tend to drive patients to seek care include fatigue, back pain, foot pain, or trouble walking. Patients who experience these symptoms have longer time to diagnosis of PsA, suggesting that there is currently a knowledge gap where these less recognized PsA symptoms do not trigger healthcare providers to think, this looks like a case of psoriatic arthritis. As we heard from John, while he did have psoriasis, he really focused on his struggles with some of these less obvious symptoms, predominantly foot pain and problems with his toenails. Because of the delay he experienced getting the correct diagnosis, his disease progressed and inflicted permanent damage to the point where his feet now are clawed. As dermatology providers, recognition of these more subtle clues as potential signs of PsA in patients like John is critical for preventing subsequent disease progression. We're also learning more about how the earliest signs of psoriatic arthritis can be present even before patients notice that anything is wrong. Jane, could you introduce us to the concept of preclinical PsA?
Thanks, Alexis. While historically the onset of psoriatic arthritis has been challenging to identify, the concepts of preclinical, subclinical, and prodromal PsA have been introduced in the literature recently as phases in the continuum of psoriatic disease that occur prior to full development of clinical psoriatic arthritis. Preclinical psoriatic arthritis is defined by the aberrant triggering of immune system signaling, often stemming from the skin, intestinal mucosa, or entheses. The next proposed phase is subclinical PsA, which is defined by silent joint inflammation or morphological changes that often require diagnostic imaging to detect, including ultrasound, X-ray, or MRI. The presence of nonspecific musculoskeletal symptoms is the key factor that defines prodromal PsA. As you may have seen in your own practice, subclinical musculoskeletal symptoms like these have been found to be quite widespread among patients with psoriasis. And in imaging studies, signs of subclinical inflammation have been reported in large percentages of psoriasis patients who did not receive systemic treatment. While no clinically validated psoriatic arthritis-specific biomarkers currently exist, elevated C-reactive protein levels have been associated with a worse clinical outcome in patients with psoriatic arthritis and have also been suggested as a component of this subclinical phase of disease development. This is particularly relevant in patients with psoriasis, as skin symptoms precede comorbid psoriatic arthritis development by 7 to 12 years. In John's case, if his dermatology provider had followed up on his foot pain and toenail dystrophy by screening him for psoriatic arthritis with one of the many existing tools that we have, this could have spurred a quicker diagnosis for him. In addition to these very early clinical signs, there are other clinical factors in patients with psoriasis that may suggest a higher likelihood of comorbid psoriatic arthritis. Alexis, would you like to speak to some of these?
Absolutely, Jane. Skin disease is strongly associated with psoriatic arthritis, and the location of a patient's psoriasis is of great importance when it comes to their risk of developing PsA. The presence of nail and scalp psoriasis each significantly increase the risk of psoriatic arthritis in patients with psoriasis. Nail lesions, pitting, and onycholysis occur in 80 to 90% of patients with PsA, and as we heard, toenail issues were a significant factor in John's experience with the disease. The increased risk of developing psoriatic arthritis in patients with these various forms of nail dystrophy ranges from 1.8 to 2.2 fold. And so in addition to the skin, the nails provide a significant window into silent inflammation in your patients may be experiencing. Telltale signs such as scale formation under the nail plate and oil spots can be key observations that lead to a timely diagnosis. Scalp psoriasis is also widely recognized to be closely tied to development of PsA. Patients with scalp psoriasis have an almost four-fold higher risk of psoriatic arthritis, making it one of the best predictors of future PsA. Finally, inverse or intertriginous psoriasis is another key predictor of psoriatic arthritis, and patients with these forms of psoriasis are over twice as likely to develop PsA. It is worth discussing psoriatic arthritis with any of your patients with psoriasis localized to any of these areas, as well as considering screening them early and often. Earlier, I stressed that PsA can occur independently of the severity of skin disease. While it is true that over 50% of patients with psoriasis and psoriatic arthritis have mild or moderate skin disease, patients with severe psoriasis or are more than 3 psoriasis sites on their skin are more than twice as likely to develop PsA. As we might expect given links between systemic inflammation and these two conditions, more severe cutaneous disease in a patient is a clear warning sign. Less obvious than skin disease severity, but even easier to assess, is family history. The recurrence risk ratio for psoriasis patients with first-degree relatives who have PsA is 39 times higher than those with no family history of the disease, making it the most important predictive factor for psoriatic arthritis in this patient population. One of the most simple and effective weapons in our arsenal is simply asking our patients with psoriasis, do you have any family members with psoriatic arthritis? In the case of John, this question would have certainly yielded dividends, as he told us his father struggled with severe joint deformations in his legs due to his battle with PsA. Another important clinical clue for PsA is obesity and/or metabolic syndrome. Recent findings indicate that up to 36% of patients with psoriasis also have comorbid metabolic syndrome, and obese patients are roughly twice as likely to develop PsA as non-obese patients. Studies in the United States, including analyses of the Corona Registry, estimate the obesity rate for patients with PsA at around 45%. The relationship between obesity and PsA is a complicated one and likely bidirectional. Both conditions are characterized by chronic systemic inflammation. Patients with joint pain may refrain from physical activity, which leads to increased weight gain, and as the body gains weight, the joints are put under increased strain and microtraumas that further exacerbate joint inflammation and PsA development. The contribution of PsA to cardiac outcomes can be clinically significant as well. A study of Framingham risk scores, which is a cardiac risk factor algorithm, in patients with PsA found that this tool significantly underestimated cardiac risk. For patients with PsA, the actual 10-year cumulative incidence for cardiovascular disease was almost twice as high as the incidence predicted by the algorithm. The close interplay observed between obesity, metabolic syndrome, and PsA should give us extra pause when considering our patients who are overweight.
Getting the diagnosis really opened my eyes. I was able to have an answer. Looking at these questions that could have been asked about this disease, it falls into two categories. Questions I didn't ask and questions that the doctors didn't ask. And I can specifically go back to a dermatologist on there.
Again, the crucial take-home message today is one of early intervention. We need to be identifying patients with psoriatic arthritis before significant permanent joint damage occurs. By keeping the clinical clues we discussed today in mind, dermatology providers can be in a unique position to help these patients. So what is the next step if you suspect one of your patients may be at risk for psoriatic arthritis? It is often useful to screen our patients using defined criteria. Multiple validated screening tools for PsA exist, and among the easiest and most straightforward to use is the Psoriasis Epidemiology screening tool, also known as PEST. The PEST questionnaire comprises just 5 patient-friendly questions, such as, have you ever had a swollen joint? Have you had pain in your heel? These can be effectively and quickly used to screen patients at each visit, and an affirmative answer to 3 or more of these questions indicates the patient may have psoriatic arthritis and should be given treatment that covers both their psoriasis and their psoriatic arthritis. Finally, again, remember that asking about the patient's family history is a key question, as there is no better predictor of a patient developing psoriatic arthritis than a close family member with PsA. Is there anything you'd like to add, Alexis?
The armamentarium of tools we have at our disposal to reach patients quickly and get them on appropriate therapy is growing every day. As John said, he views the rheumatologist that diagnosed him as his hero. Every day, we have the chance to become someone's hero by helping them reach the right diagnosis and get the assistance that they need. As our friend John says,
it's up to you to ask the right questions to your patient.